All right. Well, good afternoon, everyone. I see several people have joined this webinar, and I think we can go ahead and get started. And some of it is some basic introductory formalities, and then we will dive into the cases when a few more people have joined. So welcome to this last webinar of a webinar series. Coming to you from the BCCSU and from a collaborative known as OUD in the ED. I am Andy Kessler. I'm calling in from Vancouver, and I'd like to acknowledge that the place that I'm calling in from and where I live and work is in the unceded traditional territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. And as we go through this talk, please feel free, if you're speaking also, to mention the territories that you are calling in from. I think it's important to note that this is a rapidly evolving area of care. Some of the protocols have not been sort of completely or definitively written when it comes to opioid use disorder care in the emergency department. And so not everything we talk about is actually in the guidelines. And so we'll try to make that clear as we go, what is in the guidelines and what is not, just, and that's sort of to be responsible to our BCCSU host who make some of the guidelines. Just again, some basic housekeeping details. This is an interactive webinar. You can raise your hand and you can also post in the chat, either one. The webinar series co-chair, my colleague Isabel Miles, will be monitoring the chat and answering some of your questions in the chat, and may also bring some of your questions to the full group. We like to see you, so if you feel comfortable, please turn on your cameras. If you'd rather not, of course, that's also fine. This session is being recorded. And we are going to have a little bit of a roundup at the end of the hour, and that will give us a chance to, we'll stick around, so that will give us a chance to address any questions that have not been answered. So again, please feel free to stick around after the end of the hour. As I mentioned. And so there are a lot of materials that are online that will be from this webinar and from prior webinars. This is the link where they are posted. And just to give you an idea of sort of where this webinar fits in with the others, we started in October with the basics, then we went into buprenorphine in the emergency department. In November and December, we focused on a First Nation perspective. In January, we focused on harm reduction. In February, we did managing pain and withdrawal. And here we are in March, addressing different medications for OUD. And so if you're wondering why we're not addressing some topics today, it's because we've touched on them in other webinars, and those materials are posted online. I'd like to introduce our panelists. We have Ann Nguyen, who is a addiction physician working and living in Victoria. She also works with the Doctors of BC Physician Health Program, and she supports, she's the physician lead and supports physician wellness across BC. She's previously focused on low barrier healthcare in Northern Ontario and also in Victoria. We're also joined by Victor Jim, who is an elder and hereditary chief of the Wet'suwet'en Nation. He is a teacher of the Wet'suwet'en language, is a retired educator who worked with the BC Ministry of Education and also as an Aboriginal district principal in the Prince George School District. We're also lucky to have Sean Wood, who is a peer navigator and advocate living in Fort St. John. He teaches Indigenous engagement with FNHA, serves on the BCCSU Peer Governance Board, and has been a leader in the BC Yukon Association of Drug War survivors. And again, just briefly to touch on other members of the team, we have Isabel Miles, who is going to be monitoring the chat. She's an emergency physician and an addiction physician. We have Nicole Meyer, who many of you have been communicating with, who is taking care of admin issues at BCCSU. And we have Paula Tate, who's been a key member of this committee, webinar committee representing FNHA. So thank you to all the team. And just briefly on myself, I'm an emergency physician in Vancouver with an interest in improving opioid use disorder care in emergency departments, not only in Vancouver, but across the province. And so I will be one of the panelists today, and we'll go through some cases with Anne. We have no conflicts of interest to disclose. And at this point, I would like to stop sharing, and I'd like to hand it over to Elder Jim to give us a opening for this webinar.
Again, then elastic so na benultan. Die then tabi bawel ne ekonomistil. And ablean aleni zahnate and the day yenli. And at Scotland, it has that leak in then elastic so abakanotli. And then is that leak. Amen. Okay, I just want to say that I'm really happy to be joining you guys today. The things you're going to be talking about are important to all our people. You know, I have a son who's a medical doctor as well. He's living in Regina. He's a gynecological oncologist, and he's the only one with that title in all of Canada that's Aboriginal. So the topics you're going to be talking about are important to all our people, both Aboriginal and non-First Nation. So I'm glad to be here with you this morning. Masai.
Thank you, Elder Victor. Again, we're grateful for your opening and delighted to have you here. So I'll resume the screen share. And one of the things I failed to mention is that we have, for each webinar, we've tried to have a regional theme, and we've had different webinars hosted by different health authorities. And so the theme of this specific webinar is a little bit more Northern Health focused, because we have both Elder Victor and Sean Wood joining us from the region of the Northern Health Authority. And so again, we're grateful for perspectives in care in that region, but again, with some relevance to all of us everywhere. So our learning objectives for the day is by the end of the day, we'd like you to know how to provide a dose of opioid agonist therapy in the emergency department. We'd like to highlight some side effects and interactions of common medications used for opioid use disorder. We'd like for you to understand to some degree how opioid agonist therapy interacts with other illnesses while patients are in the emergency department. And we're going to briefly touch also on some emerging therapies and how they may impact ED care. And so this was our outline. We had our welcome from Elder Victor, and now we're going to dive into our case discussion. And again, just a reminder, we'll have, after the closing from Elder Victor, we will have an informal Q&A at the end of the hour. So this is our first case, and feel free in the chat as we go to comment on whether you've encountered a similar case and how you may have handled it. So first case, certainly kind of patient or a scenario I've encountered before. This is a 39-year-old male who comes to the emergency department during your evening shift with nausea and vomiting. He has known history of opioid use disorder, which is stable. He's been treated on methadone, 80 milligrams daily. He also uses alcohol, about 6 to 12 beers a day. And he hasn't been able to get to his pharmacy for the last couple days because he's been feeling unwell. So perhaps some initial thoughts you have are that he may have gastroenteritis, perhaps he has alcohol withdrawal, pancreatitis, maybe there's some opioid withdrawal in there too. So in your initial management, you are waiting for some labs, and you've got some, you're planning to do some symptom-triggered alcohol withdrawal management. And as this is all going on, he's also asking for methadone because he feels like he is, he's due for his dose. He hasn't been able to get it for the last couple of days, and he's worried about going into opioid withdrawal. So I guess I struggle with these kind of cases, Anne, and I'm gonna put some questions to you here about how we might help this patient. You know, I don't know how much of his symptoms may be due to alcohol withdrawal versus opioid withdrawal versus other medications. So there's that kind of uncertainty around the diagnosis or what's making him ill, and uncertainty about what's sort of safe to give him in this situation where he may be somewhat medically ill. So yeah, so I guess we're worried about the safety of giving him methadone and all the different things to consider while he's ill, and whether we need to adjust the dose because he's missed a few days. And again, if other people have other questions or thoughts about this case, please throw them into the chat. So Anne, do you have any guidance for us here?
Yeah, sure. Thanks, Andy. And thank you for inviting me to this panel. I'm really pleased to be here today. So, you know, I feel like there are sort of helpful principles about these cases in general. And this is, as you said, an incredibly common case. And I think that's maybe the first thing to recognize, which is that the thing to expect is polysubstance use rather than one type of substance use. And the scenario of opioid use disorder and alcohol use disorder is particularly common, but also opioid use disorder and benzodiazepine use disorder, as well as opioids and stimulants. And so I think always, like, the principles from a case like this are helpful to keep in mind. So I think the first thing always with a patient with opioid use disorder in your emergency department, I would even say in your walk-in clinic, is to confirm when their last ingested dose was. So of course, our first line strategy for that is checking PharmaNet. I think an important caveat, and this is a pearl really, I don't know if anyone teaches you this, but one thing you learn as you do this is that you will see, if you look on PharmaNet, that there will often be that you can't totally believe the last filled dose. So when you look in PharmaNet, when you look on the left-hand column, or sometimes depending if you use MediNet, underneath the dose, it will say filled or canceled, or another word. So you have to confirm that the dose was actually filled. Or it will say reversed. So it's really important, like when you look at a PharmaNet history, don't just look for the dates, but also look whether the doses were filled or reversed. The other thing to know is that the most recent dose, if it says filled, if it says reversed, that's fine, because that means they didn't take it, the pharmacy didn't dispense it. However, if it says filled, you may you should actually always phone the pharmacy if possible. If the patient is alert enough to speak to you and tell you what pharmacy they go to, the best thing to do is phone the pharmacy and confirm they actually ingested the dose. Because in BC, what happens is the pharmacy, they prepare the doses in the morning and they list them all as filled. And so the patient may not have actually even ingested the dose, but it will be listed as filled. So you can imagine a scenario in which you're trying to determine if they've missed 1 dose, 2 doses, or 3 doses or more, and it comes up, you know, March the 7th dose is filled. You actually don't know if they've taken that March the 7th dose or not. So kind of rule of thumb is if the patient is alert, ask them their pharmacy, call the pharmacy, and confirm when they last ingested their dose. So that's a pearl. And I would say the other thing is, if they're obtunded and they can't tell you, a little trick is that you can ask the pharmacist from any pharmacy, actually, not just their pharmacy, to call Pharmanet or Pharmacare, and they can actually go in and search for the patient's home pharmacy. You can't do that as a physician, I've tried. But anyway, these actually do become important in the management in the emergency department when the patient is quite ill. So first things first, confirm when they last ingested their dose. And so if the patient, has not missed more than 2 doses, then and there aren't confounding factors, which we'll discuss, you can give them their usual methadone dose. This fellow, though, he has confounding factors. So we'll talk about that. Should I talk about that now, Andy? Or
Yeah. I mean, I think it would be good. I mean, we've got 3 other cases to tap your wisdom on. So
sure. Okay.
so
I'll keep it moving.
looking forward to
Yeah.
all the skills you got. Yeah.
So I mean, and I guess because I realize I'm talking to a room full of people who are already working in the emerge, and so I kind of want to make it really pertinent for the things you're going to see, rather than sort of reviewing a lot of basics. But if I've missed some basics, absolutely let me know. So the other things to consider with this patient in particular, but generally patients who show up in your emerge, is so the other factors. So he has alcohol use disorder. You've got him on a symptom-triggered CWA, and so he's going to get benzodiazepines, probably, unless you're giving him phenobarb, but whatever. These are sedatives, right? And they're long-acting sedatives, and methadone is a long-acting sedative. So that's the biggest factor to consider, as well as acute illness that might be causing respiratory depression and somnolence and decreased LOC. So what you give the patient really depends on all those factors. So how much benzo has he gotten? Like, it's really different if he's gotten 20 of diaz versus 80, or 200 of diaz or 200 of phenobarb, right? So you would consider those factors. You would consider how recently he had taken methadone. And then, and the basic sort of, rule is that if they've had a bunch of sedatives, or if they have another reason to have a respiratory depression or a decreased LOC, you might want to decrease the methadone dose. You might want to split the methadone dose. I do that regularly. You can split it. You can split the regular dosed BID or TID. And I usually would space the doses at least 3 hours apart so that you can observe the peak of methadone. And then you can always give them short-acting opioids in between so that they don't go into withdrawal, right? So those are just some principles that I routinely use. And I guess, another kind of pearl is that any doses of methadone or things that are given in hospital, OAT that are given in hospital, will not show up on Pharmanet, like, ever. So just keeping that in mind. Yeah, is that a good place to start, Andy?
Great. So are you suggesting, should we call the pharmacy if we give a dose in the emergency department, just so that they're aware?
Yeah, you don't have to call the pharmacy to tell them you're giving a dose, but it's always good practice. So, at St. Paul's, the addiction medicine fellows are trained to do this. Every time a patient comes into the hospital who's on OAT, you confirm their pharmacy, you phone their pharmacy, you cancel their existing prescription, because, their prescription probably goes on till, the next week or what have you. You want to cancel, you want to confirm when their last ingested dose was, cancel their existing prescription. And for purposes of documentation, of course, I don't always remember to do this, but it never hurts to say, I phoned the pharmacy, I confirmed their last dose was March the 6th, and I've canceled their prescription. And then that just alerts the team in terms of just good care and handovers. Yeah.
But just to clarify, it sounds like maybe you're talking about when you're pretty sure a patient's going to be admitted, like this guy, maybe we don't know.
Yeah, that's true.
Maybe we'll get him turned around in,
for sure.
a few
Absolutely.
hours.
Yeah, for sure. Yeah. So if that's right, because given that I'm a consultant, I only see usually people after they've been admitted, but absolutely, if you're in the ED and this person may be turned around, then you definitely want to let their pharmacy know. So,
no, thank you. That's really helpful. And I'd love to get your input, Sean. I mean, maybe tell us what's going through, let's say in this case, this guy is actually, he doesn't feel well, but he's pretty alert. He's got some concerns. How can we, work best with this patient from your perspective, and making him feel more comfortable in the ED, that we're going to kind of address his needs, but that we also got to kind of balance that with his safety. I'm not sure if you're muted, Sean, or can you hear us?
There we go. I can hear you now. Yeah, I lost.
Okay, great.
For some reason, I missed like half of what or a quarter of what she was saying there.
Oh yeah. Well, I guess our question was just the scenario was a guy who uses alcohol and opioids, comes in with some nausea and vomiting, and interested in getting his methadone. He's already missed a couple doses, but we're on the medical side, we're also a little worried that we're going to be giving him a bunch of medications that may interact, and that he may be, that it may be a little risky to give him all his methadone, let's say.
He did miss the dose before. Honestly, we're experts on our own drug consumption. We're alive for a reason. Medical models are very, very well and very, very studied, I feel. But there's days that my tolerance goes up and down as well. But having missed days or a day or two beforehand, and coming in and to take care of the co-occurring, I would just give him a half a dose roughly, or is it ask what you ask the person. What do you, because when we start to get sick, it's not so bad as there's a brutally honest part in there. And then once they're full blown withdrawal, I noticed it doesn't matter. Just give me whatever, however you got it. I'm not making it until I'm stable. So it's, we missed the 3 days prior, like at least half. Depends on why did he miss it? Was he using like street drugs, or was he just homesick withdrawals, or had some medical condition that kept him at home, or no ride, or however, because it is like a sliding scale. It's like for a lot of us on this side, it's well, we get stable on it, then everybody has a bad day, right?
Yeah.
And especially now with the fentanyl, it's just really, it's the addiction seems to be worse.
Yeah. No, thanks, Sean. That's really helpful. And I think what I'm hearing loud and clear from you is just to really, the patient is the expert in their own sort of condition, and get their input and work with them in terms of what the person thinks he or she needs in terms of getting their needs addressed. So that's really helpful.
Yeah.
Just in the interest of time, I want to keep moving. I wanted to hit the take-home points that I think, Anne, you mentioned. I think you talked about the importance of checking for missed doses on PharmaNet, and notifying the pharmacy if we think the patient is getting discharged, and to prevent some double dosing. In somebody who's also sick, we want to think about their metabolism. If they're, let's say, have hepatitis, and if we're having to treat them for opioid withdrawal and giving them, alcohol withdrawal and giving them a bunch of benzodiazepines or other sedatives, we kind of have to take that into consideration when we're giving their OUD or other opioids. And then intermediate release opioids are always an option. And I think Sean kind of reinforced that also. If somebody's really in bad withdrawal, that they'll probably want anything that could get them through that. And I think, as you mentioned, also the methadone is not going to kick in right away also if somebody is in really severe withdrawal. And yeah, we can always, especially with someone with sort of two different disease processes going on at the same time, always a low threshold to get input from an addiction consult. And then I think just the guidelines that you didn't mention specifically, but I think Sean alluded to in terms of the number of days missed. There's, by the guidelines, no need to change the dose if you've missed just 1 or 2 days, but to have a reduction if you miss 3 or 4 days, and if you've missed 5 days or more, it's essentially new start. I see a couple of hands up there, I think from both Melissa and Anne. So yeah, go at it before we move to the next case.
I definitely think that getting a second opinion sometimes is really helpful. So guidelines are helpful, and at the same time, like there are patients who can tolerate like really good doses of methadone even when they're sick, and so you're always trying to balance like retention and care with safety, right? And so for a patient who's say like on 150 of methadone and they're still using like half a gram of fentanyl, 30 of methadone is going to be like probably not enough, and they could probably tolerate more. And a more humane dose might be like 40 or 50, which would be off of guidance. But so that's a scenario where you might want to call your friendly addiction medicine friend through the race line or through, we'll give some numbers at the end. The other thing too is that we often split doses for a variety of reasons. So safety, another one is pain control. So if a patient has like a really painful skin and soft tissue infection, we'll split the dose because theoretically it improves analgesia. However, I would definitely say that, to echo Sean, the patients are the expert on their conditions. So if I ever think about splitting doses for some sort of reason, and I think the patient really should have input on it, like the safety thing I have to be responsible for because I'm the doctor. However, if I'm thinking of splitting the dose for analgesia, I will always ask the patient first, like, what do you think about this? I'm thinking about this. And a lot of patients, sometimes patients will say, try it out. And sometimes patients will be like, no, I just want it all right now. So I definitely think consulting, the person, it makes, is important.
Thanks, Anne. And Melissa?
So I see people like this as a community prescriber, and I don't have access to Pharmanet. I used to have access to Pharmanet when I was associated with the clinic, but then when you're not associated with the clinic, you can't get it unless your hospital gives you permission. And I think you guys can get it through your Cerner in VCH. You have access, but Meditech doesn't give us access. It's a whole, if anyone has help, can help me get access. So I haven't been able to have my own prescriber associated with the hospital. So we get the MedRec sheets, but that's not the Pharmanet. So just so emergency docs, at least in Fraser, realize that, right? So when I see patients like this, the first thing I do is think, like, as an emerge doc, is there something else going on? Like, rule out all the medical things. Maybe it's like, maybe he's septic or, has COVID or something else. And then the way to get around checking their Pharmanet is you have to go to the clerk and look at their screen, and they can pull up the full profile for you. So just any docs, if you have time, you can do that. And then I just talk to the patients also, like Sean was saying, like I'll just tell them, if you've taken your methadone and I'm giving you another dose, it's going to cause you trouble, right? And like have a really like honest, like human conversation with them about how you don't want to double dose them, and you'll give her other things. And I found most people who are on methadone will, like, they're not there to like get extra doses of their methadone, right? So yeah, so sometimes I'll give them a half dose, and then they're okay, I'll give them the other half like a few hours later if they're okay with that. The other thing in community emerges to think about for community emerge docs is that most community emerges don't stock methadone, except in small tablets. Like they'll have the 5 milligram tablets. They don't actually stock the syrup. We have to get it brought from the pharmacy. So if you're thinking somebody needs methadone in a dose more than sort of 20 milligrams, to order it early so it can be sent down to central pharmacy and bring it up, because central pharmacy will close, especially if it's after hours, because central pharmacy usually closes at like 7 or 8, and then they have to call someone in. So just think to order it early, because it takes a couple hours to actually come to the ED often. And then patients get irritated and want to leave when they're not getting their methadone. So those are just some practical things.
Thanks, Melissa. I think those are great points, and reminding us that we all sort of practice in slightly different environments with different resources and have to find some workarounds. So we'll move to case 2, and I think what I may ask, just in the interest of time, is you keep your definitely raise your hand if there's just a quick point of clarification, or you think we missed a major point. Otherwise, maybe save some of those additional pearls and wisdoms or questions for our wrap-up period after the end of the hour, just so that we have enough time to get through the next couple cases. So this This case is a woman who comes into the emergency department early in the morning. She's got some flu-like symptoms. She uses opioids about 1 to 2 points by injection daily. She is on slow release oral morphine or Cadian, 1,000 a day. And she was unable to get to the pharmacy today because she's been feeling unwell. You do some investigations and you see her kidney function is down. Her GFR is 37, and she also, you find out she's COVID positive. So you're giving her some hydration, and you are planning to admit her to the hospital because you're worried about she's got this renal injury and she's got COVID and is, relatively ill. And she's asking for a dose of her Cadian, and because she says she's starting to feel in withdrawal, and if we can't do that for her, then she might just take off. So I think this brings up a lot of the considerations from the last case. Also, so important. We want to really keep this person on their OUD therapy, retained in care from that point of view. We don't want to lose her when we're actually worried about her kidney function and other things. But I think I remember, Cadian having some renal metabolism, and we may have to adjust things there, or just adjust things in general because she's sick. So how should we address her needs? I'll turn this over to you, Anne, and sort of what are sort of the top sort of safety things we should be thinking about, and how can we address her needs so that she stays in the emergency department?
Yeah, totally. I'll be pretty succinct because I know we have a bunch of cases to work through. So, my top concerns here are, she's got COVID, she's sick. She missed today's dose, which is fine, but the main thing is that her renal clearance and her potential respiratory depression and the potential to go kind of sideways respiratorily quickly, and retention and treatment, like treating her humanely, like, she needs substances to remain engaged in treatment. So you're always trying to balance that, right? You underdose the patient, you're going to make them uncomfortable and they're going to want to leave, but you also want to be safe, right? Because we also don't want to have to give a patient Narcan, which makes them very uncomfortable as well. So, basically the principle here is that you could hold the Cadian, the SROM, peaks in sort of 8 to 10 hours actually, and give short-acting opioids. So you can give short-acting morphine, you can give short-acting hydromorphone. So her renal clearance at 37 is kind of on the borderline. Like, you don't technically have to reduce morphine with a renal clearance over 30, but she's kind of getting close to the edge, and she's in AKI. So I might choose to give hydromorphone, which you can give orally, you can give as an elixir. Some hospitals have that. The elixir works a bit faster. You can also give it IV. There's no harm in giving patients IV opioids, especially in the ED, like on the wards. Sometimes giving high dose IV opioids is tricky because of nursing protocols, but you might as well take advantage of the fact that you're in the ED. And if giving an IV opioid would keep the patient more comfortable, like, go for it. So, oral IV hydromorphone, probably I would hold the SROM, but I'd be aggressive with the short-acting opioids. Or if I gave the Cadian, I'd probably split dose again, right? So rather than, she could tolerate, can she tolerate 1,000? I'm not sure, because of her other illnesses. So, I might be ballparking, giving her a total of, say, 700 or 800 as a base and splitting that, TID. So maybe giving a dose of 300 of SROM, or you could go like something else, like maybe, 8 of hydromorphone PO, 4 of hydromorphone IV, something like that. Q1 to 2 HPRN, depending on your nursing capacity. Always looking out for signs of opioid toxicity, of course, which we know. So like pinpoint pupils, myoclonus. Same thing, if she seems pretty sick, it seems like you're going to admit her. So, the whole pharmacy notification thing is not urgent. And then, of course, always like a low threshold in these sick patients for calling addiction medicine, whether through the 24/7 line or your friendly addiction medicine consultant.
Yeah, no, thanks for all those points. And then I'll turn it over to you, Sean. Any sort of any more guidance or tips from you in terms of, how to, again, I think just like before, we're definitely going to ask her what she feels would be right for her at this time, but any other tips for somehow reassuring her that we got her back? Or
I don't, making her comfortable would be the biggest one. Privacy, comfort. Like if she's threatening to walk out, if you don't get it, you gotta assess whether it's a serious threat or is she just trying to push her away because she's withdrawing or because she wants what she wants, or that it kind of brings in a different realm of questions too when somebody says that.
So yeah, so comfort is really a high priority there. That makes complete sense. Good, thanks for that. And then I guess we'll keep moving along, and just if I can just reiterate what sounds like your major take homes there from Anne. We're gonna again look for missed doses on Pharmanet for somebody who's on OUD. We're with somebody on Cadian, we have to think about the renal function and possibly change it to something like hydromorphone that is not renally cleared, if especially if the GFR is below 30. We have some guidance up here also on this slide about if somebody just missed one day, you don't need to change. That's sort of if everything else being equal, if they're not acutely ill. And then there's some further reductions if they've missed several days. And do you think that I summarized your main points appropriately, or did I miss something there?
No, I think that's great, Andy. I think, the little thing, if you don't want to remember this table, is I always think for missed doses of Cadian, it's the number of missed days multiplied by 20. So if they miss 2 days, it's a 40% dose reduction, 3 days, 60%. The other thing too is, a point that Sean brought up, Melissa brought up, and then Isabel brought up in the chat, is that just talking to the patient frequently and explaining your rationale, like, hey, my goal is to keep you really comfortable so that, because you're sick and we want to treat you. So we're going to try this and you let me know how things are going, and then continually reassessing the patient. That's just a general rule in medicine, but especially in addictions, right? Like when managing alcohol use disorder withdrawal and opioid withdrawal, like we're going to try this for these reasons. You let me know how it's going, and we can always adjust, keeping in mind safety and your comfort. Like my goal is to keep you comfortable so that you can get the treatment you need, right? And you tell me. So I feel like those are great principles to just always keep in mind.
Thanks to you and to Sean for emphasizing that. Yeah. So our next case is a 24-year-old guy who comes in with a rapid heart rate. He's had fevers. He's seems a bit excessively sleepy, and he's got a productive cough. You make a diagnosis that he has pneumonia and sepsis. And in his past medical history, we know that he has opioid use disorder, also uses stimulants 3 to 4 points a day. He has been on methadone 100 a day. His last dose was yesterday. You're planning to treat him for community-acquired pneumonia, and he gets ceftriaxone, azithromycin, and some fluids pending, and you're waiting to admit him now to the hospital. Somewhere along the way there, you get an ECG on him, and you see that he has some QT prolongation with a QTC of 510. Before it was 410. And here he's still pretty sleepy and sick from his pneumonia, but he is asking for his methadone and saying that that's really important for him here. So so this guy makes me a little bit nervous. I guess he is on methadone, which prolongs the QT. He's sick. We already gave him a medication, azithromycin, that can prolong the QT further. And so what can we do? What should we be thinking about this guy who's, one, he's sleepy, two, he's got this QT prolongation. How do we kind of balance this sort of, again, this safety and his substance use needs?
Yeah, I mean, I think that again, like, so all of these cases and what we do in addiction medicine in general, there's the what and there's the how, right? So we'll talk about the what and then we'll talk about the how. So the what in this case is that one, the patient is sick and they're sleepy and they have a prolonged QT. You've given them a medicine that can further prolong their QT. And like, this is not a joke. Like, you can get a fatal arrhythmia from a torsades from a prolonged QT. So we have to take this really super seriously. So yes, the patient really wants methadone, but this is where communication really makes a difference, right? And where you say like, hey, I totally get you want methadone. I would too. However, I could kill you if I give you methadone right now for these reasons. And I really don't want that. So this is what I would propose. And what I would propose is, probably not even dose reducing the methadone, but holding the methadone, given the QT of 510, and giving short-acting opioids. And I would say to the patient, I'm going to give you lots of opioids and keep you really comfortable. And basically, if you can talk to me and you're awake enough and breathing and tell me that you can take it, I will give you more, because I'm really concerned about keeping you comfortable, but I need to keep you breathing at the same time. So, dose reducing and giving, whether it's short-acting hydromorphone, short-acting morphine elixir. This is actually where IV opioids are great again, because it will peak really quickly. You can observe the peak. So yeah, give like, whether it's 2 or 4 of IV hydromorphone as a test, and see if the patient, does anything change in terms of their SATs or whatever. So I would definitely, in this case, probably go on the side of holding the methadone and again, explain to the patient, as soon as things kind of get better and stabilize, you're on this antibiotic for your pneumonia, and then as things improve, definitely our priority is to get you back on the methadone, right? So I think that's the how of the case. And in terms of like the kind of rationale, I think as we've talked about, methadone can prolong the QT interval. The risk of arrhythmia like definitely increases over a QT of 500, and especially over methadone doses of 100. And the reality is, if the end game is to keep the patient comfortable and engaged in care, we have other ways of doing that. But that's kind of where the artfulness of medicine comes in. We need to engage the patient and meet them where they're at and help them understand why we're doing what we're doing, right? So, I mean, you could also consider switching to another long-acting form of OAT if the patient would permit. So Cadian could be, potentially, but again, I'm not keen on Cadian in this scenario because of his pneumonia and again the long-acting nature of it. I'd probably prefer, at least for 24 hours, to just do regularly scheduled and aggressive PRN short-acting opioids, and then see how things go. And then the patient will show us if they can tolerate it or not. And then we'll say, hey, listen, I know long-acting things. The other thing you can take solace in as a provider is methadone has a very long half-life, right? It has a super long half-life. So if he took 100 yesterday, he still has 50 milligrams in his system, right? So I think those are the principles. And I think, that principle of like the tolerance that the patient has in the community is very different than in hospital, especially when they're really sick. And we're responsible for the safety of the patient.
Yeah. No, I think it sounds like a great approach. Sean, do you have anything you would add to Anne's approach here?
Yeah. So just to clarify, is he a dual addict, like dual substance use issues, or I wasn't clear on that one.
Oh yeah, I think in this particular case, yes. I think he also uses, if I recall, I think this gentleman also uses stimulants. Yeah.
Okay. Yeah, I read it. I didn't see the. I've seen 3-4 points. I do daily. Yeah. Well, it just brings me to more question that except I've come across this like personally. What about the stimulant use disorder? And the withdrawals on that. Yeah, giving him a higher dose of his medication, opioid is going to help the opioid issue and sedate some of the outer of the stimulant, but the inner part of the stimulant, the mental, the physical, and everything like that isn't being addressed either. And to reach out, lash out a little in different ways. So I mean, I'm personally myself, just out of experience, edibles, strong edibles, my body slows down, but my mind doesn't. and I'll twitch, and I'll have adverse reactions for being too sedated, causing panic or whatever inside and externally, right? So I don't know. This is a tough one. When I first read it, I thought it was just stimulant use. I was like, why are you giving him a methadone or anything first, just a stimulant use? So that was now that I got that cleared, but yeah.
Mm-hmm. I think that's a good point, Sean, to just keep that in mind. And before we move on to the next case, Anne, do you have any words of wisdom of how you would sort of take the stimulant use into this picture? And is that contributing to the somnolence of this patient? And would you do, if he's in stimulant withdrawal, and would you do anything about it during this phase, or,
Yeah.
or hold off, or what?
Yeah, thanks so much for mentioning that, Sean, because like it's totally potentially at play. I mean, we definitely see folks who have, they're coming off of stimulant intoxication and they sleep for 3 days and they emerge, right? So it could be contributing to the somnolence, but it shouldn't contribute to respiratory depression, right? So if the patient's withdrawing from stimulants, then usually what happens is they're tired, they're sleepy, they're kind of depressed. But in this case of this patient, I mean, he's got that partly from the pneumonia as well. So I would say like stimulant withdrawal, typically, it's treated with a number of things in the emergency department, like sometimes but actually we usually just let the patient kind of sleep it off in quotes. And I'll usually ask, like, I just talk to the patient. I say, hey, I know that, or you told me, or I saw in your urine that you've used X, Y, or Z. And what do you feel like you're withdrawing from right now? And so if they feel like they're withdrawing from, usually actually when I ask people, they don't tell me too much they're withdrawing from stimulants. So normally I can't say honestly, Sean, that I've had to respond too much to that, but I will always ask the patient. And I'll especially ask that, like, often people get really uncomfortable withdrawal from marijuana, actually. So if you're using like a ton of weed, like 2 grams plus a day, you're gonna get like anxious and, all sorts of things. So I think that the overall picture is ask the patient about all the substances and what they're withdrawing from. Tobacco withdrawal is really uncomfortable too. And that's something we can treat. So ask the patient and then see what you can do about each substance, particularly about stimulants though. I don't really have a medication answer for that.
Yeah, stimulants does a lot about nervous, external nerve, skeletal nerve issues and anxieties that touch, which I've been stimulant addict since I was 14, 15, so 41 now, quite versed in the withdrawal of it, and then the minor parts that affect others. So I like your answer on it, and it's some definitely needs to be looked at, because anxiety is maybe need more places than anything, and that's part of it.
Yeah, thanks. I think that's really helpful, John, just to remind us to sort of address, all the substances that may be at play, and both in the patient's comfort and in their illness at that moment. So thanks, Anne and Sean, for your comments there. And if I just want to summarize your points, I think the main points you made is that tolerance in the community can be pretty different from tolerance in the hospital when somebody's really sick. And that being pretty sick, like this patient was, can definitely impact their tolerance. Methadone, in terms of its danger of causing arrhythmias, along with QT at any dose really, but that risk goes up if the dose is over 100 milligrams. And then if the QTC is greater than 500, then you've got that significant risk of torsades or a dangerous arrhythmia. And so you would also, of course, in their care, address all other factors that might prolong the QT. In terms of the methadone, you might hold the dose completely or reduce the dose, and also, as you really emphasized, and in this case and also in the other cases, when in doubt, you can order the intermediate release opioids. And as you and Sean have pretty much stressed in every case, also of just really letting the person know what your rationale is, how you're going to keep reassessing and seeing what's working for them, and addressing all their needs while they're ill and in the hospital. Great. We have one more one more case that I think is relatively maybe a little bit quicker, and then we'll pass the feather back to Elder Victor. This is a 26-year-old female who comes in with upper extremity purulent cellulitis. She has a few superficial abscesses that you were able to incise and drain. She does have a history of opiate use disorder. She uses about 0.5 gram of fentanyl a day, both IV and smoked. She's had recent non-fatal overdose. She's on no medications. At this time, her goals of care are not interested in being abstinent, but she is interested in being safer with her use. Previous trials of methadone, Suboxone, and slow-release oral morphine, and it hasn't really worked for her. So she comes in requesting, she's heard about risk mitigation and safe supply, and she comes in, asking you about getting some hydromorphone that might be safer than the toxic drug supply on the streets that she's been using. Yeah, so this is something pretty new, and I certainly don't feel like I don't understand all the ins and outs of it. So, what do you do if somebody asks you about this, and sort of where does it fit into the care of a patient like her or other patients with opioid use?
Yeah, thanks, Andy. So maybe just to start answering the questions point by point, risk mitigation is a strategy that was endorsed by the BC Centre for Substance Use in March of 2020 at the beginning of the COVID pandemic. And the goal of the risk mitigation guidance was to help separate. It was in anticipation that people were sheltering in place and would go into withdrawal. And when people went into withdrawal, one, it would be uncomfortable, and then they would be increasingly have to turn to the toxic drug supply, which is of course full of fentanyl and now novel benzodiazepines, as well as horrible other sedatives as well. So that was the spirit in which the risk mitigation guidance was written. And so what it actually looked like in practice was that it enabled prescribers in British Columbia for the first time ever to do things like prescribe long-acting opioids, OAT, and daily dispense short-acting opioids. So that was a practice prior to March 2020 that was never done among OAT providers. I mean, except perhaps in hospital when a patient was very ill. But basically it's saying, okay, so you're on 100 of methadone a day, however, you're continuing to use the toxic drug supply. I am now enabled as a prescriber to give you up to 14 tablets of Hydromorphone 8 per day, so that you will not feel like you need to turn to the toxic drug supply in the street. So that's the purpose of risk mitigation. And risk mitigation also applied at the time to things like prescribing short-acting stimulants to people with stimulant use disorder, prescribing benzodiazepines, et cetera, et cetera. But again, the whole goal was to support sheltering in place. Very quickly thereafter, like within weeks and months, I mean, really the toxic drug supply, like who is at risk of dying? Everyone who uses street drugs is at risk at all times, right? So you can imagine it made a lot of sense really for so then community OAT prescribers started getting asked like, hey, can I get on this risk mitigation stuff? Because as we know, for many people, being on a long-acting opioid, so being on OAT works for a lot of people, but it also doesn't work for a lot of people, meaning it reduces their use of the illicit drug supply, but it doesn't reduce it to zero. And so people, for a variety of reasons, continue to desire and pursue street use, which is people's right to do. And so risk mitigation was then sort of utilized and prescribed fairly, I would not say widely, but it was prescribed a fair bit between Victoria and Vancouver, as well as a smaller amount in other jurisdictions to help people separate from the illicit supply. I think it's important to state that from an evidence-based perspective, there's not a body of evidence to support risk mitigation prescribing. It's based on really the desire of clinicians and the requests of patients to do something about this horrible drug poisoning situation that we have. I think that the jury is still out as to whether it is successful or not, meaning it is actually doing what it says it should do. And so there's just been a revision that's been put out by the BC Centre for Substance Use on risk mitigation. And you can go on the website and learn more about that. How do you use it in practice? I would say that the most common use of risk mitigation currently is not for sheltering in place, but for experienced OAT providers, we use risk mitigation in the early phases of titrating someone onto OAT. So, if you're using a 0.5 gram of fentanyl a day, starting someone at 30 milligrams of methadone for a week is not going to cut it, right? So by adding, say, 14 hydromorphone per day daily dispensed from a pharmacy with your daily dose of methadone, it's still not going to cut it, but hopefully it takes a bit of the edge off while you're titrating up the methadone, the buprenorphine, the Cadian. How would I approach that request in the ED? It would be pretty hard. I probably would not do it in the ED, frankly, because you don't have a long-standing relationship with this patient. I would probably send them to the rack. If you can, you certainly maybe give some short-acting opioids to tide someone over if they definitely don't want something. You could offer something like a dose of Cadian, maybe with 1 or 2 doses of risk mitigation, maybe 8 hydromorphone, but I would not write a week-long script from the emergency department. And if you're thinking of doing it as an ED physician, call the 24/7 line, call an addiction medicine physician to back you up, document it on your chart. Those are my answers.
Okay, well, and that's really helpful. And but I think it brings in mind to question when you mentioned it was just being done in Victoria and Vancouver and a few other jurisdictions, and it reminds me of a conversation I had with Sean earlier, and maybe Sean, you can tell us a little bit about if people up north have heard about this and what's available, what's not available, and for those people on this call who may work up north that may help expand some options if this is not kind of either widely known about or used up north.
Excuse me. I'm actually one of the only stimulant people users on the risk mitigation guidelines up here in Fort St. John in the Northeast up here. And it has successfully got not only myself, but 25, 30 other people that I know off of the illicit market. Stabilizes way faster, gives us our personal autonomy, lets us decide really, and then therefore we have an open conversation with our doctors, prescribers, mental health people that we talk to as well. Levels us right out. It takes a guessing game out of whose supply you're going to buy from.
Mm-hmm.
That's massive for anybody. And then like I take mine in the morning. I got an open script till July. And then I don't get a doctor after that, but I haven't had a doctor for 4 years, but it took me 6.5 months to get on it. Up here, they're very, very dead set against it. And one of the most terrifying things for an addict to do is to go into an O clinic and be told that they're going to be on this for 2 years. They're going to be chained to this for 2 years. The likely comparison to being in jail and institutions.
Mm-hmm.
It's tied to something. It's just something in the back of the brain that just goes, hey, wait a second. And that's scary because they don't know what they're doing tomorrow. Right? I don't know what I'm doing tomorrow kind of deal, right? So it's longer to stabilize when you're on a regimen because a lot of us don't like to listen anyways. That's why we are where we are most of the time, right? So I mean, there's and in the north, like no, there's very little. There's a lot. We got a lot of pushback from the college pharmacies, or college doctors and physicians, and a handful of pharmacists are actually really well up on it because they're the ones that see us more than the doctors, right? And see the mess and the games and everything like that. And they're basically the champions up here when it comes to the middling that. Really, there's a few of them, and they'll have these conversations with us, and. It was the first year of it was they kind of could my pharmacist would talk to my doctor, but he could change my script a little bit if something wasn't working. You gotta have that full conversation with your doctor when you first get on it. but yeah, it's done wonders for me and my family, my reconnection with life, and several others, right, that I know really well. So yeah, that's like I can't say nothing about it. Maybe good about it. Like there's I haven't seen much bad, not up in the anyways.
Well, thanks for sharing that experience with us, Sean. I think I hear sort of 2 points, and one is that it gives you and some other people a lot more autonomy, like what's going on with them. Nobody likes to be sort of tied to the same regimen forever. And also that it sounds like it's starting up north, but that there's still a long way to go. And that's probably true in some other jurisdictions as well. So thanks for sharing that with us. I just want to hit the wrap-up points there that just want to make sure that I understood Anne correctly. I think it's risk mitigation is still in the early days. It's not yet evidence supported. We think, but we're not sure that it's going to reduce some of the deaths from the toxic drug supply. Could be, it's probably not something we want to regularly initiate from the emergency department, but again, we might want to consider it as a bridge for just, 1 day or 1 or 2 days for just a small supply to, if somebody's titrating or if somebody needs to make it to an OUD clinic in the next couple of days, and giving them an alternative. And again, as you mentioned, always call for help. So I think, did I miss anything, Anne? Anything else you want to add to that?
No, not at all. We're having a lively chat about diacetylmorphine in the chat.
Okay,
So,
great. Okay, so I'm just in 1 second, I'm going to hand it back to Elder Victor. I think this is just to show people, this is the 24/7 line that we've been talking about. That is staffed by the BCCSU 24/7. You can call from wherever in the province. Taking additional training like the POTSP course from the BCSU is always an option. And then, part of the reason for us doing this webinar series, if you don't have time for the POTSP course, is providing additional resources such as this webinar, and some associated documents and learning materials that go with this. So right now I'm going to turn it over to Elder Victor, and just to remind everybody, we will stay on afterwards to answer any questions that we still people want to discuss still.
I'll open with a short prayer, and then I'd like to make some comments and maybe some suggestions. Aqua tenes dutli, urake jin hanzuela jin reneunina. Again, abuzik eten agayistik. Die den dabi stasa kanunistil. La nur teni yetlea. En nesudizil. Teni Norenlin is genabenultan. Erat Zena no neslierne aber sadlich. Honzu gen abeslestin nesudizil so ke udaqid teni nubeatahni so genabenultan. Amen. I listened to the cases, and I think one of the things I might suggest is, how it affects our First Nations people. Lots of our First Nations people have aversions to going to the hospital because of the treatment they've been getting, and seems like forever, eh? So that is something that maybe you can think about in the future, is how do we try to make things better for our First Nations people? Because lots of them have not been going to the ERs or the hospitals or their doctors because of things that have been happening to their friends and relatives. And I realized that, you know, and in my prayer, I asked the Creator to guide the doctors that are helping everybody out there with the problems that you guys were talking about. And I think that, you know, once, because we've lost lots of young people to drug overdoses in Vancouver, Prince George, and other centers where our people live. And, you know, we've been really fortunate that we've only lost one this year to drug overdose. But in the bigger cities like Vancouver, Prince George, we've lost about 6 or 7 last year, just from our community. And these are all young people. And, you know, in our system, the young people are the ones that are going to be looking after us as we get older. And it really hurts when they leave at a young age. You know, it's getting more and more difficult for our elders when they see lots of our young people passing because of drug overdoses and whatnot. So it's just something to think about. You know, you guys are working in some really stressful situations. And, you know, I appreciate the work you do. And I hope that things get better for everyone once the pandemic is over. This pandemic has been really hard on everybody, including our people. And I just want to thank you for the good work that all of you are doing in helping our people in this province. I would say.
Thank you very much, Elder Victor. I think that's a great way to close. We're grateful for your presence with us today, and thank you for the reminder of thinking about the needs of all our patients and maybe the special needs and of those who are Indigenous and have a background of trauma in hospitals and other environments. So thank you for that reminder. I'd like to again, thank you to you and all the panelists and those of you who participated. We will stick around with anybody who is interested to answer any questions or have a further discussion over the next 15, 20 minutes or however long people want to hang out.
Okay, I'll be leaving you. I got to get back to my work.
Okay, thank you so much.
Thank you so much.
Yeah,
So nice
you're
to
welcome.
meet you.
You're very welcome. Have a good day.
You too.
You know, what Elder Victor said reminded me, like before I worked in BC, I worked in Northern Ontario, and I was in a little community called Sioux Lookout, which is kind of on the vanguard of buprenorphine. Like they started all these community buprenorphine programs. And I always say, if you want to look for innovation in medicine, you go to the periphery, because people you know, the situations Melissa describes with resource shortages or not being able to access X, Y, or Z medications, like people are just so resourceful. And there's amazing innovation happening in addiction medicine in, you know, rural hospitals, rural emerges. And, you know, it was interesting when we first started prescribing buprenorphine in Canada, like 10 years ago or so, or we used to treat it like methadone. It was bananas, right? Like we'd make people witness every day and stuff. And now we just like, let's put it in the water. Let's give everyone a week. But who was on the vanguard of that? It was people in rural communities. Because if your patient has to drive 40 minutes to see you, you're not going to make them witness every day. And they really put their necks out for patients because, like, you know, we are always worried about the college, right? So I just really want to thank our people who work in these more resource stretched areas for being like gutsy and really putting the patient at the center. Which I think is, you know, we're always trying to balance safety and patient-centeredness, but I really think there's like tons of innovation in the smaller areas of Canada.
Yeah, it's a great point, and I think just a recent example of that is with sort of the Timmins, Ontario sort of rapid induction on Sublocade, which again is sort of like a smaller center being super resourceful and coming up with something new.
The sort of general attitude is like, why not, right?
Great. I see Isabel is set to head out. Thank you for supporting the chat, Isabel. All right. Any for those, Melissa or others who've been monitoring the chat, any things that came up that were maybe not, we didn't get a chance to discuss yet?
If no one else has something to say, so what do you guys do with Pharmanet at VCH? Like can you guys access it through Cerner, Andy?
Yes, we can access it through Cerner, and then in places that don't have Cerner, or at St. Paul's before we had Cerner, there would always be a sort of a printout on the on the chart.
That is the MedRec form though, which isn't which is just that day. Like it doesn't go, so you can't.
No, we would get the. I mean, still, I guess at VGH, which is not yet on Cerner, they do. You get two things. You get the MedRec, but you also get the Cerner printout.
Where it says it shows you the daily dispenses.
Yeah. Yeah.
Okay.
So there is a way. I mean, it was the I think it was the registration clerks he had access, and
Yeah, they have access.
And then they would print it out. But yeah, I can see how that would really limit your,
No, you just have to walk to that registration clerks and ask them either to print it out or just have a look at it. You just can't like get on yourself.
Right.
I don't know. The last time I checked was like 2 years ago, and then I got so frustrated with Pharmanet, I just.
But it's all about trying to be low barrier. I mean, we've been talking about reducing barriers for patients, but obviously reducing barriers for providers is the same thing. I mean, if it's not super easy for you to check Pharmanet, you're not, and then you may not know that this person in front of you with an ankle sprain was on methadone a month ago, and that if you hadn't seen that, you're probably not going to address their, ask them about their opioid use, or you might not.
I would add, like that's a real institutional commitment. Like my work in Victoria for the last 6 years up until the fall was I worked in a community health center, like the only community health center in Victoria. So like similar to Three Bridges in Vancouver. And this practice has had Pharmanet for like 10 years. We just pay for it. So we use Medinet. So I think that's like the institution's commitment to being low barrier. Like it's weird, frankly.
So it isn't. It's because Pharmanet itself connects to not providers. It connects to clinics or hospitals.
Mm-hmm.
So like as a provider, you might have Pharmanet access, but they don't, like, if you're ever audited, my understanding is you shouldn't be accessing, like you have to have Pharmanet access for every particular, like every specific place you're working.
You should.
So like what I used to do is use my clinic access wherever I was remotely, but really that's
But I guess
illegal.
my question is, why doesn't your hospital pay for your Pharmanet access?
So the hospital does have access, but they don't provide it for every provider. Like I can't click into it myself. I have to go into like the registration clerks. So that's why, because there's like hundreds of people.
Right. So, but that's
go into Medinet myself, right? So
But I think that's your institution. I mean, I would just say like a bunch of you maybe could consider pushing your institution to give you access. Like that's part of an institution's commitment to addiction medicine, say, or through patient safety, like, I mean, I know you guys have like so much to do, so I'm not wanting to put another thing on your to-do list, but I guess I would just be saying to your institution, like, why doesn't every physician really, or everyone in the ED have access to Pharmanet? And maybe if that's something the BCCSU could support even, right? Knowing that, clinicians have a lot on their plates, like, to me, that's because actually in the BCCSU guidelines, like if you're going to prescribe methadone or OAT, you have to have PharmaNet access. So like, we need to be pushing institutions to give their clinicians that access.
Right. Yeah, I have a different, I think, yeah, I have a different perspective in that PharmaNet should be individual based, not
It should
clinic or
also be
institution
free.
based. So
It's public information. They
right,
shouldn't be
issue,
charging us
right?
for it, right?
It's because as a locum, you also don't really have access. You have to like apply for every place you're working.
Mhm. Yeah,
But
I think those are good.
Charles, someone wants to.
I think, yeah, Charles had a question about learning resources, and I think we're hoping that some of the slide decks from this webinar series are going to be part of that resource, and we're going to further develop. We have a few FAQs related to the webinar material, and we're going to try to make more of them, where sort of every webinar topic we've covered will have some FAQs for sort of quick digestible information. I think I think there's a rewriting of the BCCSU guidelines with one sort of a more dedicated chapter for emergency care and emergency issues, but that's been a long time coming, delayed by COVID. And so, yeah, I think that's part of the reason we're doing this webinar, is because I think there's still not that sort of short of going through all of POTS-P, which has a lot of stuff that is not relevant to emergency care. We're still kind of short on resources that are really targeted to OUD care in the emergency.
Yeah, sorry, I realized I gave you misinformation there. The update hasn't come out about RMG yet, but I got a sneak peek at our addiction medicine meeting. But
Got it.
yeah, the summary is basically that it's going to mainly endorsed for use of up titration of OUD for OAT in the early phases, and stimulants with caution, because most of the benefit we see in RMG in stimulant use disorder is in patients with suspected ADHD. So I think in terms of how it applies to an emergency physician, I would mainly just be aware of it. So when your patient tells you, I'm getting 14 hydromorphone a day, or I'm getting like 40 of Adderall or 80 of Ritalin a day, and you're like, whoa, that seems weird. It actually is probably legit, and you can check that out on PharmaNet, because this is a practice. I think I more so than you actually doing it from the ED is my sense.
I think they are out.
Are they? I was on their website and I can't find the new update, but that's the summary. So, oh yeah, cool. It looks like the update is out. That's great.
But it's too long for
You're right.
us.
You need an executive emergency summary.
Short attention span people. Yeah. I mean, I think the other thing that I find, hearing that a person is on risk mitigation, or seeing how much they're getting on PharmaNet, helps me also have a feeling of their tolerance. If they tell me they take, they'll pop 4 or 5 tabs at a time, and then if they're in sort of early withdrawal or in pain in the ED, I feel like, okay, well, I can safely give them that dose, or fairly safely. That's where I find it's helpful seeing that risk mitigation on PharmaNet if I have some
totally
acute pain or withdrawal needs to address.
I wish I had said this during the main webinar, and I know you often work, evenings and weekends, but if ever you can directly speak to someone's primary care provider, OAT provider, it honestly saves a ton of time. And I would say, especially in the risk mitigation realm. And the other thing about OAT providers is they have to have an on-call backup service, like to answer questions. So as an example, I have, as an addiction medicine consultant, seen PharmaNets with like oxycodone 20 tabs per day, plus Cadian 1800 per day. So if that person shows up in your shop and you're trying to make some decisions about them, if you can, I mean, again, it's not always possible. I know you work funny hours, but if you can connect with their OAT provider, whose name will be on there, I find OAT providers are among like the most accessible and happy to talk to clinicians people, because they really care about, their patients a lot. it helps a lot, actually. Like, you know, like help me understand what you're doing or thinking here. Like oftentimes, because we're trying to meet our patients where they're at, you will see, like I recently was working and I saw a patient on 500 of methadone with weekly carries, plus short-acting hydromorphone, plus hydromorphone at bedtime, who also had AUD, which is like probably one of the wildest scripts I've ever seen. However, I mean, the benefit of working in Victoria is we're a smaller community than Vancouver. I know all the doctors practically. So I just called up the patient's doc and I was like, and I know this is a really excellent physician. And I always find as a consultant and as a specialist, and you know, like, please be kind to people's GPs, right? Like we see things on PharmaNet and we're like, holy crap, what the hell was this person thinking? Did they want to kill this patient? Nobody wants to kill a patient, right? But really, like when I talk to this person, it's like the patient had been homeless, they're palliative, they've got all this stuff. And this doctor is just trying to retain the patient in care, right? And then the patient has a spouse who's monitoring their carries. And so it's always like, if you can have that conversation with the GP or with the OAT provider, especially when the script looks really wonky, it can help a lot. And it can just save, like, because I think things are so hard in medicine right now. And when honestly, like when our colleagues in the community get like a judgmental note from a specialist, it really crushes people. Like, I can't believe the GP was thinking X, Y, or Z, right? So I think it behooves all of us to be as kind as possible with each other and stuff. Anyway, just putting a pitch in for family medicine.
Sounds great. Thank you.
No. Thanks for all you're doing and being interested in addiction medicine. Yeah, it's great.
Well, thanks for making it digestible for us.
I don't know how digestible it was, but tried to. This was really fun. Thank you for inviting me, Andy.
Thanks, Anne. Good. Well, I think we're good for today. Again, I think Nicole will be sending around some documents or evaluations related to today, or maybe you already did that in the chat, Nicole. And again, thanks again for panelists and you and participants.
Okay, bye.
Bye, everyone.